Welcome to It's Your Case, presented by VetCT.com. I'm Heather, your radiologist on demand. Today's example, a 2-year-old Australian Shepherd who was hit by a car. Now, when a patient presents with an emergency situation like this, we are all tempted to abandon our systematic approach and dive right in to look at the abnormalities. For most of our videos, I focus on the important findings. For this video, I will instead walk through my entire approach. This is intended to serve as a reminder that even when in an emergency situation, and in fact, especially when we have a patient who really needs us, we must go through a systematic approach so that we don't miss anything. For thorax, I always start with the lateral view. I often use a multi-screen approach, but for this video, I'm going to focus on one image at a time. I like to start by looking at heart. When I look at this right lateral view, I can see that the heart doesn't appear large, but the caudal margin of the heart is not seen. That's because there's border effacement with all of this soft tissue pathology. I would then quickly check on the other view and see if I have an impression about heart size. Now, you might say, hey, the right heart looks somewhat generous in this case. We're going to come back to that because in my opinion, this is actually because the heart is being a little bit displaced. The second thing that I look at once I've looked at the heart is the lung. If we skim the right lung in this patient, you can see that generally speaking, we have appropriate opacity within the right cranial lung and also within the right caudal lung. In the region of the right middle lung lobe, for me, I see a mild increase in soft tissue opacity. On the left, the lung is partially obscured by this pathology here, and we can see that there's a focal alveolar pattern. I would characterize this as an alveolar pattern because it has increased opacity, and I don't see pulmonary blood vessels. It's even causing maybe a little bit of a lobar sign. The left cranial lung lobe area looks much more normal. I keep all of these findings in my head when I go back to the lateral view and try to corroborate. This is a right lateral view, which tells me that here is what I'm seeing is a better view of the left lung. And I can see that again, my impression is that there's a focal alveolar pattern, increased opacity, faint air bronchogram, no really ability to see the pulmonary blood vessels in this region. Continuing on from the pulmonary findings, I would then look at pulmonary blood vessels and the airways. The cranial lobar vessels are best assessed on the lateral view. When I trace them, you can see that they're actually quite small. This is also detected in other lung fields, but is less apparent because of the concurrent pulmonary pathology. Looking at the airways, and I'm going to go back to the other view to show this. When I trace the trachea to the mainstem bronchi, I can see that there's cranial displacement of the left. This is relating to this pathology here, which we can finally get to now that I've looked at heart and lungs. So you can see that there's a large gas opacity with kind of curved margins located in the left caudal thoracic region. This is highly consistent with cranial displacement of the stomach. When we look at the lateral view, you can see that there's this bulge associated with the diaphragm that goes cranially and that it indeed does contain part of the stomach. There's a little bit of evidence as we're looking at the pleural space of pleural fluid characterized by mildly increased opacity in this region, reduced conspicuity of the ventral cardiac margin, and on the VD view, there's a few thin pleural fissure lines. I would also then, especially in a patient that was hit by a car and has this type of pathology, take the time to assess each and every one of the ribs and vertebrae on both views. I do this by tracing them with my eye and often following along with my mouse. I go up one side of the thorax and down the other. On the lateral view, I like to follow the ribs in a zigzag pattern. For the vertebral column, I often go through the vertebral column twice, especially when a patient has trauma or neurological signs. The first time, I look at the vertebral bodies and the disc spaces, and the second time, I look at the spinous processes and the synovial articulations. On the ventrodorsal view, assessment of the vertebral column can be trickier, but in the lumbar region especially, we need to take care to look at the transverse processes. Now, to summarize our findings, once we've done a systematic review, there is a left diaphragmatic hernia with cranial displacement of the stomach, some scant pleural fluid. The lung changes that we see are most severe on the left, but a little bit in the right middle lung lobe, and these may be due to contusion from the vehicular trauma and or a component of hypoinflation and atelectasis from the diaphragmatic hernia. One thing that I didn't mention yet is what is the status of the cranial abdominal organs that we can see? Well, we can see, of course, as we've discussed, that the liver is that the stomach is displaced cranially, but I think that the status of the liver and the spleen should remain open. We don't really have enough on these views to determine whether they could be partially involved with the diaphragmatic hernia. So be sure to review the full report associated with this case. Thanks for listening, and remember, it's your case, so please post your questions on social media.